So thank you very much, Lena, for keeping to time and an excellent session. And I guess it's interesting for MSF to think about online violence and gender-based violence and broadening out our concepts of gender-based violence. And maybe our first response is not necessarily to do the research ourselves, but at least to be aware of that evidence and incorporate it into our programs wherever we can. Our final session for today is research in emergency settings. I'm going to ask Dr. Uni to come up again and to chair for us. His bio is in the notes. It probably hasn't changed since this morning, but knowing Uni, that is still a possibility. And I hope you will engage right till the end with questions, 3 more presentations with questions, and then we're there. And this is the crunch time. Thank you very much, Uni.
All right, great, last session. So bear with us for, 45 minutes or so, and it'll be time for drinks. Allow me to take a moment to reflect a little bit on what we've achieved during the day. MSF sometimes makes it look easy. The number of research that is being done and the quality of research belies the fact that these research is often carried out in some of the remotest parts of the world in difficult settings. The challenge, of course, is always to make sure that humanitarian assistance that we provide is relevant and effective, and that takes a lot of work. So it's not just dumping assistance, that we really want to make sure that the assistance we provide works. And that's why we do the research we do, we try to understand the context as we do, and this year particularly I've been really encouraged to see the number of qualitative studies that have been presented today. Having said that, last session we are going through the most difficult context in which we work today. You probably hear about what's going on in the Middle East. In the last year alone, the dangers that are faced by doctors and our teams in contexts like Syria, in Iraq, in Somalia, in Yemen has been tremendous. Hospitals are being bombed almost every week. In Yemen, I hear that women rather give birth in caves rather than come to hospitals. Hospitals are no longer the safe spaces they used to be in times of conflict. So even in these sort of conditions, to be able to take the time to really explore and understand whether our assistance that we provide is actually effective and is the right thing to do is actually quite an impressive thing. So it's with great pleasure that I introduce the last 3 presentations. The first 2 are from Yemen. I don't need to tell you more about Yemen. It is one of the worst humanitarian crises of our times. This is a country and a city that's being bombed daily, and I think our teams are doing extraordinary work. There's a cholera outbreak that's going on at the moment. And the last one is focused on refugees. Today, I think we have the largest number of people displaced at any time, I would like to say in history, but at least after World War II, for sure. So again, thinking about how can we provide the best service possible to refugees, displaced people numbering about 65 million in the world today. So, having said that, let me invite the first speaker, Dr. Nishanth, to talk about Yemen. And Nishanth kindly sort of agreed to present a paper that is not his own. And so we're happy for you to present the paper and offer your comments on Yemen. And then we'll invite Dr. Kalyani after that. Thank you.
Thank you, Dr. Unni. It's been a long day for all of us already, and I promise not to make it any longer. So I'm Nishanth Arulappan, and I worked in Yemen before and during the current conflict. However, I have two disclaimers. I have not worked in Hajjah, and I don't have a background in mental health. The authors of the study couldn't be here today, so I'm doing this on their behalf. How does the context in Yemen influence mental health? A Wikipedia page for civil war in Yemen lists 13 conflicts starting from 1948 up to now. This clearly shows the high risk of conflict relapse in this country, and the chronicity of the conflict can definitely predispose vulnerable populations to psychological problems. Yemen experienced its own version of the Arab Spring in 2012, following which a transitional government was installed. However, armed tribes from the north began to revolt against the government, and they mobilized all the way down south. This opened up a lot of new front lines and also drew international actors into the conflict. And with a few exceptions, most of the front lines remain static, and this in turn has influenced IDP movements inside the country. There were heavy airstrikes in two of the northern governorates, which caused a massive influx of IDPs into the governorate called Hajjah. In addition to this, fighting along the western coast and also along the southern front line caused influx of IDPs into Hajjah. And right now, Hajjah hosts almost half of the 2.7 million IDP population in Yemen. MSF currently works in 8 of the governorates. We have been working in Hajjah since August 2015. We are supporting Qaeida Hospital in the ER, ICU, surgery, IPD, maternity, and referrals. And just in 2016, we treated almost 3,400 war wounded and the survivors. How did mental health fare in Yemen before the war? The data is not very recent. In 2011, WHO observed that there was one psychiatrist for every 500,000 of the population. Now, compare this with high-income countries where you have 9 psychiatrists for every 100,000. And the stats on the psychologists and social workers are much less. And as of, even right now in Sana'a, there are about 40 psychiatrists, and they are all the psychiatrists in Yemen itself. There are about 4 mental hospitals with a capacity of 850 beds, and the resources in the private sector is not that great. There are 4 psychiatry departments and 11 psychology departments in all the various universities throughout Yemen. Now, the culture in Yemen closely links mental health illnesses with magic, witchery, with witchcraft and sorcery. And because of this, there's a lot of social stigma towards mental health illnesses, and this leads to neglect as well. And traditional faith healers are normally the first line of approach in these cases. In 2001, WHO estimated that there was about 20% of the population suffered from psychological or emotional disturbances, which was almost 4 million back then. And in 2006, approximately 30,000 patients frequented or sought mental health care. In terms of ranking, paranoia and schizophrenia came first, followed by depression and anxiety, and they also mentioned epilepsy, though it's strictly a neurological condition. What is the MOH doing about this? Till date, there is no officially approved mental health policy. Mental health legislation doesn't exist, and there is no data on the expenditure in mental health from MOH. As I said, Hajjah hosts almost, and why is this stuff relevant in Hajjah? As I said, Hajjah hosts almost half of the current IDP population, and there are absolutely no mental health specialists in Hajjah, and the other local NGOs that were involved have closed shop due to problems with the budget. So we decided to intervene in November 2016. So this study collected data on all the patients who received individual psychological support between November 2016 and Feb 2017. And though the impact was interesting, there were some unique challenges that they faced. The first step was to train 2 MOH counselors in recognizing the reactions to traumatic events. They preferred to say reactions rather than symptoms, so that the beneficiaries would not view their reactions as something abnormal or negative, given the pre-existing stigma of mental health in the culture. So the next step was to train the other MOH staff to seek for these reactions in the other patients in the other departments of the hospital. And in addition to this, our MSF staff were also trained in psychological first aid and psychological interventions in mass casualty events if MSF has to evacuate. So the whole purpose of this was to streamline referrals to the mental health team. That's a training session in progress. And so the numbers. With the group intervention with the MOH counselors, there was about 2,224 beneficiaries, and among them, 209 beneficiaries received individual psychological support, And out of that, there were about 11 people who shared common traumatic experiences, and group counseling was done with them. So in addition to the first consultations, there was about 289 follow-up consultations, sometimes even up to the 7th session, making it a total of 495 sessions. There was a default rate of about 21%, mostly because either the patients had moved to another place, or they came from a very far away place, or some of them simply couldn't be traced. Now, in terms of the demographics, males formed almost 57%, and almost 80% of the males were more than 18 years of age. And the females too, this category was more than 80%. Now this slide, as you can see, in terms of source of referrals, shows clearly the impact of the intervention, as more than 40% of the referrals was from the psychoeducation sessions done by the MOH counselors. And next came the sources from our MSF and our MOH staff. And finally, it says comment by others or family members. What does this mean? Word spread around in the community that MSF is doing mental health interventions. Sometimes they do training sessions. I mean, they were doing the sessions even in the hospital waiting rooms. So word got around, and people brought in patients to the team. In terms of diagnosis, the big four was psychosis, depression, PTSD, and anxiety. Though they did encounter patients with chronic mental conditions, following the first session, follow-up sessions were not done, and these patients were managed by the MOH. In terms of precipitating factors, violence arguably was the largest component, and combined with what you see in that green sector, 10% separational loss due to the conflict. So 85% was directly related to the conflict. And there was other precipitating factors, almost 11%, where people with chronic medical conditions, like patients with renal failure, diabetics, who couldn't access the dialysis centers, or the dialysis centers had shut down, or they couldn't get their insulin, that was also a precipitating factor. What were the main challenges? First, there was challenges on the pressure on the recruitment of the candidates for the team. And there was also a significant stigma associated with gender-based violence and HIV. And the confidential nature of the counseling sessions was not very well received. And some doctors refused to respect the guidelines for psychotropic prescriptions. And referrals to psychiatric hospitals and other areas was problematic because of problems in transport or difficulties of follow-up. However, the positive thing was that there was a very good acceptance from MOH, and MOH said we'll keep these services on even if MSF decides to leave. What would be further be required would be baseline anthropological studies to better understand the cultural attitudes towards this, and also to plan interventions for sensitive issues like gender-based violence. And I'd like to thank, the first authors would like to thank the staff and the patients of Yemen, and I would like to thank the editorial team, especially Safia and Ryan, for the inputs on this talk. If you want the references, meet me after this. Thank you.
Great presentation for a stand-in presenter. Right? Great presentation for someone who's just stood in. Tremendous. Great. All right. Any quick questions that you may want to ask?
Yeah, I have the data with me, so if I don't know.
No, but because this is the last presentation on mental health that we have. So if there are any questions that you have about the context or the program itself. Yeah, Alan?
I still hear a bit in MSF that if we do mental health, it's not the core, it's a bit of a soft topic for people like MSF. But we see it's a growing need, and it's a need that's unaddressed in a lot of the world. Should we as MSF, and I'm opening it should be doing more in mental health?
This is for you, Dr.
All right. I think the need has always been recognized. The problem has always been what to do about it. I mean, even in our own societies, there are different approaches to deal with mental health. Compound that with, different culture, different language, it makes it very difficult to implement a mental health program. And also, you're right that we tend to hold, we have a higher rigor, scientific rigor for physical health programs than we have for mental health programs. But that, I think, has been changing in the last, again, in a place like this, mental health, one of the challenges of providing mental health care is that people continue to live in the traumatizing conditions that cause the problems in the first place. And that is a problem. So psychological first aid is something that we talk about a lot, but we have to do more work to actually see how effective these programs are. And I think we are putting in more effort, but there's much more work to be done. That's it. You had Magali? No? All right. Okay, so then I'll ask Dr. Kalyani to come and again, the context is Yemen, but we are moving to the emergency room from the counseling room.
Good evening. With a lot of information load since morning and with burning questions on your mind, I request you to give a few more minutes. The idea is to stress on the relevance of research and data analysis even in emergency settings. Again, I have to own up that this is not my original presentation. This is a presentation which was done in MSF UK office by Stefano, and I'm presenting on his behalf over here. But it's good to know that I was in Yemen 3 times in different parts of the country, and as my predecessor explained, Yemen has been through a lot. The context is very complex. The activities is also dynamically changing all the time. So it's just to show how we try to figure out what was the need for the population and try to adapt to the services. And I would be taking pride in saying MSF almost like achieved to manage something in a very volatile context, which is still ongoing, thanks to our colleagues there. So we are going to talk about the activities of an MSF-supported hospital quite close to Thais, where intense fighting has been taking place for more than a year, a sort of siege-like activity. For a year, and now still we are running the facility. So this map shows where we are in Yemen, at least focus. So the hospital which we are talking is somewhere between Ib and Thais. We do have facilities in Ib, a tertiary level referral hospital from the MOH. In Thais, there was OCA having a maternity and child and trauma center as well. And then the Al-Qaeda was a secondary level MSF-supported hospital. We prefer to call it as Kilo instead of Al-Qaeda, which is for us a little bit not very okay. So at the beginning of 2016, we took over the hospital in the governorate, the Kilo hospital. So this map shows you how the political or the military situation is there and how it is relevant to our context. Just to add a word, the green portions are the portions which are sort of with the coalition or the coalition supported government. And then the purple areas are I would say it is a faction of who's fighting the coalition support. Then you have also the Al-Qaeda actually areas which are dominant with them. So it's a sort of like they were having parallel governments which also impacted our activities to some extent, because I remember in Iba hospital that you have the government regional hospital and then you have a parallel hospital for the Houthis. They have one system of referrals, they have one system of taking care. So it was not very easy working in that. But it was very good for us in Kilo that every party agreed to respect MSF rules of not having weapons inside. We initially started the project with the idea that we thought because of the intense fighting happening over in that area, we would receive and treat a lot of civilian wounded patients. But when we analyzed the data, we found that it was interesting to note that we were looking much more beyond than violence due to weapons alone. So the Kilo hospital, as you see, is a very nice hospital in a very beautiful place. We had an emergency room with almost around 6 beds, 1 OT, 2 ICU beds, but we did not have ventilator capacity. We had a 50-bedded IPD, which included post-op, female, male, and pediatric as well. And the maternity section was being run over by MOH and supported to some extent by us. I was there when they were preparing to start the hospital, and then one evening they were still installing, and then they got the first patient who came in with appendicitis, interestingly, in an area where there is fighting all around. So our first patient to be operated on was an appendix patient. This is a standard data tool we use in most of our emergency projects. I will explain in a moment how it was relevant to use this tool and how much information we could get from that. The basic objective of this study was to assess the quality of data from the Qaeida Hospital and how the standard reporting could help us figure out the needs of the population, and also to review the activities of the first 11 months, whether it was of relevance to MSF to be intervening there. The data basically comes from the ER register mainly. I will be talking only about it, but it's also linked with the OT register, ICU register. The data is collected with maintaining confidentiality, so we just put the initials and then unique identifier number. But the IPD data, we just go in for the aggregate numbers. So in this, there is a column called the arrival time of the patient, and then you also have delay to arrival, which indicates like whether there was a problem in access for the population to access our health services. There is a column which is called referred by, which also indicates how the population, whether they came by themselves or whether we had other hospitals referring them and whether transportations were available. We have to take into account that moving from the idea was close to be around thighs. Imagine there were so many checkpoints that the patients had to pass through to reach our service even. So it was not easy for the common people to cross the checkpoints if they belong to one faction or the other. The ambulance services even have to undergo the scrutinization, be with proper papers or something to access the services, which was also interesting in this context. And then the time of initiation of care would reflect upon our ER efficiency. The diagnosis gives an idea of what we are primarily looking at. And the procedures form, unfortunately, in this project, because of the emergency context, we couldn't, we could have gone a little bit more in that, but we would see that in the succeeding slides. The volume of activities, this shows the resuscitation room and the ER room. We had 8,411 consultations during an 11-month period on 6,000 and odd patients, which is probably a little bit controversy. Probably the rest of them, the discrepancy is due to the follow-up consultations wrongly being entered as a first-time ER. The median age of the patient was around 20 years and predominantly male. The type of activities, surgical and non-surgical. So when we talk about emergency room, we are talking about like surgical and medical emergencies. Primary aim was stabilization, and if it's stabilization, surgical, it probably will be in our OT, except for complicated complicated orthovascular injuries, which we had to refer. So coming to the surgical breakup, this is interesting because we expected trauma violence to be a bigger one than the trauma accidental. And we found that trauma accidental, which was mostly because of motor vehicle accidents, falling from height, children falling from height, injuries, fractures, and all sorts of things. Acute abdomen to some extent, and C-sections equally because we had the MOH facility. This is about triage by color. We were using the typical 4-level triage system of urgent, immediate, delayed, or palliative. And interestingly, we found that those people who access our services were 4,000 was yellow cases, and the red cases were 900. The green, normally it's the green sometimes, or red, but then it is interesting to note we had the large number of yellow cases. And then coming to the outcome with the triage color, the number of patients discharged was 4,000. Admitted was 1,500, so 465, default died, and then you have the referred. When I say referred patients, these are the patients who were referred to the next level of facility, next level of care with MSF referral letters. And you have a large population of discharged patients with the yellow and red cases. So let us go to the individual breakup of this. So in the green cases, 687 people were discharged, and around 10% were admitted, which probably is over triaging. Coming to the yellow cases, 186 people were discharged and 1,200 and odd were admitted, referred, or probably died, which is acceptable, you would agree, because most of the discharge also means they went for further consultations, which MSF was not normally referring. It is to be understood that the orthopedic cases, MSF believes in doing external fixation in emergency situations and not internal, where the population demand in Middle East was more about internal fixation, and then they would go on their own to IB hospital or to their private practitioners to get them. Or probably there were cases which were admitted in IPD, stabilized after a couple of days of treatment, were discharged home. The red cases seems to be fairly equally doing good compared with the outcome. So it is accepted norm from the American College of Surgeons that over triage rate of 50% and under triage of less than 5% is acceptable in emergency situations. Coming to the procedures, this is a breakup like we couldn't, as one of the limitation was not being able to train the staff who are entering the emergency room data to correctly capture the information into our books, even though we did a lot of procedures. The trends during the 11 months, you can say that the community acceptance of our hospital was relevant, was very good, because you see the case numbers going. And interestingly, the surgical and non-surgical at the end of month 12 is almost like equal. There was also an increase of women to access our service for cesarean section. Let me remind you, in Yemen, the repeat cesarean is almost like 15% and more. So women were happy to come to our hospital. In the beginning, it was not easy for them to access our service. So the conclusion is like, yeah, standard reporting in emergency room, the data, whatever we try to collect when waves of injuries or people are coming into the emergency room in a very complex security situation, is reasonably adequate to help us identify what are the needs, what is our efficiency of care, and to go in for more in-depth investigations of where we want to focus our activities. There's also an improvement needed in long-term assessment of what happens to the patient outcome, how the patient was referred to our own setup or outside, or where is the patient ending, and what is the recovery rate or disability or whatever is happening. It's good to identify that, okay, we still continue to work because the numbers show that people are accessing our service and the need is still there. And it is interesting to note that there is a shift from the original target patients of surgical and now non-surgical are almost one and equal. Of course, we still need to work on our over triage. The limitations of this study is we didn't have, this is a retrospective study with the approval, because it was a retrospective study, we didn't need the medical ethical board review, but it was okayed by our Geneva operations control. There is, we couldn't control the data when we were when we were collecting this. The procedures again underreported. There no long-term outcome data is possible with this study. So, if you have any questions for me, but before that I would like to thank all the past, present and future workers who still continue to work in Qaeida Hospital. And with the cholera coming in, it's still getting more busy.
All right. I'll take one question. Santosh has got his hands up. Yeah.
On questions, just 3 questions I have. It's like two. One is that what was the situation of did you have any anesthetist assistance? And if there was an assistance, why didn't you start an internal fixation? Because like internal fixations are quite common in all ward settings now. So it's like it is giving a final solutions to the patients, and patients with the external fixation. It's like they need to go back, and usually they don't come back at all. So if you give an internal fixation, it's almost like a final solution. And the third question is like, what about trainings? What was the quality of people you got from the community, and did you have any training sessions for them?
Very aptly asked question from an orthopedic person, like why we didn't go for internal fixation. As a standard MSF policy, if I'm right, Dr. Muni, that in acute emergency context, MSF believes the care for the life-saving, limb-saving procedures, and compared to the amount of people we could treat with a limb-saving procedure with external fixator and the luxury of doing an internal fixation. Obviously, we need to match our resources and the needs of the community. It would be ideal, and especially in a country like Middle East where they are used to more sophisticated procedures, it was very difficult convincing the people like, hey look, this is MSF policy, we will only go in for. Second thing, we did have anesthetic people, but we were there for acute limb saving and life saving surgeons, and the capacity, we did not have orthopedic wing as such. We were focused more on a life saving and limb saving procedures with our general surgeons, at times if we're lucky, with some orthopedic background for that, for one thing. It was not our criteria when we established the Qaeida Hospital to take on all the orthopedic cases, because the bed occupancy rate would be quite high as well. We will not be able to have such a turnover of the patients. We couldn't afford for that. Trainings. Believe me, it was really difficult to get even the normal staff required for the hospital because of the context of keeping people. We tried to do, of course there is a training all the time going on, every week, every time, but then to get the people to come and work in that area was itself not very easy.
Yeah. All right. Just one comment. A couple of times in your presentation you talked about identifying needs. Analyzing hospital data. I think we have to be very careful to infer needs from analyzing hospital data. I think you only get a real sense of the needs if you do a community-based sort of study, because there are a lot of people who do not make it to the hospitals, and we don't fully know what the needs in the community are. So I can understand that you analyze patient data to provide better service in the hospital and kind of get a sense of patient profiles, but that does not equate automatically to needs in the community.
I stand corrected. It doesn't give the full picture of what is exactly in the community.
Yeah, but I understand that in an emergency situation may not always be easy, especially in an emergency situation, to go and do community-based surveys. Thank you very much. Yeah. Very quick, please. We have to move.
I'm sorry. Thanks. I'm a pediatric cardiologist. Just one thing. In training, when you are dealing with emergency in such a dire situation, we often follow the criteria so, do, to. See one, do one, and teach one. That is the best way of training, and it goes a long way. And secondly, when you were dealing with these kind of situations, ethically, all the universal precautions were followed. You never mention anything about the universal precautions.
I'm sorry, we take it for granted that in MSF, the quality of care would be at international standards, and it's a part of the initial orientation training to any staff to adapt to universal precaution. There's no question with the infection control and universal precautions.
Most important.
Yeah. Thanks for reminding that, and Yeah, regarding C1, we are more talking about the emergency room triaging. I would feel comfortable if we are over triaging and take a green patient in and admit, rather than under triaging an yellow patient who I had to lose later just because the staff were not. As such, emergency triaging is not very well practiced in most of the places. It's even in India a very new concept of like when you receive mass casualties or in a busy emergency room, to make them understand that it is not that the most devastating looking injury is the most serious one, to put them into their mind repeatedly to that, okay, you have to do a proper triage if you want to save more lives within the limitations we are having. Yeah.
All right.
Thank you.
Thank you, Kalyani. Sorry, we have to rush you off the stage. The last presentation of the day, we have Ruby Siddiqui on modeling Hep E vaccinations for refugees.
Thanks for staying until the end. I'll be presenting on behalf of Ben Cooper, who did the modelling work for this study. So hepatitis E virus is thought to cause about 20 million infections globally every year, about 3 million symptomatic cases and about 70,000 deaths. About 20% of those that are infected develop clinical symptoms, and we see a case fatality rate of about 2% in non-pregnant cases, but this increases tenfold in pregnant cases. MSF has responded to a few outbreaks, most recently in Darfur, Uganda, South Sudan, and Chad, all of which were refugee emergencies, except Chad, which is an urban emergency. Hepatitis E is endemic in Asia, in South Asia and Southeast Asia. It's estimated to cause about 10% of pregnancy-associated deaths in Bangladesh, and maybe 10,000 pregnancy-related deaths in South Asia. Transmission is fecal-oral, and although hepatitis E virus has been isolated from surface water bodies in Darfur and in South Sudan, there's an increasing body of evidence that indicates that person-to-person transmission within households is the most likely explanation for the transmission patterns that we see. In terms of control, water and sanitation responses are thought, the impact of water and sanitation responses is uncertain. And in terms of treatment, options are fairly limited, only supportive care really. But there is a vaccine. It's safe and effective, and it's called Hekalin, or HEV239, but it's only licensed in China in 16 to 65-year-olds that aren't pregnant. Its effectiveness was deduced in a large-scale randomized control trial that was published in The Lancet in 2010. And that was carried out in an endemic region of China, but its potential impact in an outbreak setting is uncertain. So we decided to look at that through mathematical modeling. Firstly, by estimating the key epidemiological parameters that are associated with transmission. That's things like the basic reproduction number that tells us how many secondary cases will result from an infected case. And then use those parameters to build a mathematical model where we can then explore the impact of vaccination both before an outbreak occurs, that's preemptive, or after an outbreak has already occurred, that's reactive. And then to go on to look at extending the vaccination coverage to other age groups and pregnant women for which the vaccine is not yet licensed. So as I said before, MSF responded to an outbreak in Uganda in between 2007 and 2009. It was in a refugee camp in Kitgum in the north of Uganda and resulted in 10,000 cases and 113 deaths. About 50% of those cases occurred in just 3 of the camps. That's Agoro, Madiope, where the outbreak started, and in Palago. So we fitted a deterministic compartmental transmission dynamic model to the 3 outbreaks. let me just explain very quickly what that means. Basically, you can divide individuals in the population into different compartments depending on their infection status, and then they move between these compartments depending on transmission dynamics. And I'll explain that a bit better here. Model 1 shows an SEIR model, and individuals can be divided between these 4 compartments. S for susceptible, that's not immune and not yet infected. E for exposed, that's latently infected but not yet infectious. I for infected and infectious, and then R for recovered and immune. The bold arrows point to the direction of individuals between the compartments, and the dotted arrow indicates influence. So in this case, infected and infectious individuals can influence the rate at which susceptible people become infected. I'll only show the results for Model 1, but as you can see, we explored 6 different models that express the uncertainty around transmission dynamics, but they all gave broadly similar results. So this is the model fitting, where we adjusted the values of the various parameters until the model fitted outbreak data. Here in circles, we see the real data. That's the weekly number of hepatitis E cases in each of the outbreaks in Agoro, Madiope, and Palaga. And if you look at the colored solid line, that's the model fit. So you can see that we have pretty good fit to each of these outbreaks. And then during that model fitting, we can home in on the true values of the model parameters. That's moving from the peach color to the red color, and so a much narrower definition of the parameters. And similarly, we used Bayesian analysis to explore the vaccine effectiveness distribution from the Lancet article that was published in 2010. We assumed a coverage of 80% and a dose interval between the first and second dose of 1 month and between the second and third dose of 5 months. There was no data in that trial to show that any effect from a single dose, so that was excluded from the analysis. So we plugged all of those parameter distributions into the model, and this is what we saw. This figure shows the reduction in the number of cases in gray, the number of total deaths in yellow or orange, I'm not sure what you see, and the number of pregnancy, deaths in pregnant women in blue. And on the left-hand side, you can see the different groups that are vaccinated. And this figure shows reactive vaccination, that's vaccinating using 2 doses after the first 100 cases of an outbreak. And we can expect to see up to about 30% reduction in the number of cases and deaths. The figure on the right shows the same scenario, but reacting much earlier after the first 50 cases. And we can see that we can expect reductions of up to about 45%. In both cases and deaths. But the thing to remember here is that the vaccine is only licensed in 16 to 65-year-olds that are not pregnant. So when we're looking at the other groups, we're assuming that it's safe and equally as effective in those groups. And another thing to notice is that in this scenario, if we're not vaccinating pregnant women, we're having no impact on deaths in pregnant women. And that's because we're not responding fast enough to achieve herd immunity when we need it, which is actually at the start of an outbreak or before an outbreak. So that's what we investigated next, preemptive vaccination before an outbreak starts. And you can see already that we're seeing much larger effects if we vaccinate before an outbreak, if you compare to the top row here. Another thing to notice is that if we vaccinate everyone else except pregnant women, we can see an effect in reducing deaths in pregnant women. And that's because we're now starting to see an indirect effect of vaccination, moving towards herd immunity. Another thing to notice is that if we simply add pregnant women to the group that the vaccine is already licensed for, we can see that we don't see much effect on the number of cases, but that we do, actually maybe I should use my pointer. We don't see much effect on the number of cases, but we do see a huge impact in the number of total deaths and the number of deaths in pregnant women. And if we use the whole of the 3 doses before the first case preemptively, we can, and we're vaccinating everyone, we're moving towards herd immunity and reducing almost 100% of cases. So in conclusion, reactive vaccination can lead to important reductions in mortality, particularly if we implement this early in an epidemic. But there's potential for much greater impact if the vaccination is preemptive, particularly if the vaccine can be shown to be safe and effective in pregnant women and children and older age groups above 65. The results were robust to extensive sensitivity analysis with different model assumptions, but it's unclear to what extent the results were generalized to an urban setting, such as the current outbreak in Chad, and to endemic settings, such as what we see in South Asia and Southeast Asia. And these need further research. And these are my acknowledgements. Thank you.
Thank you, Ruby. Before I open it up, am I correct in thinking that the vaccine is currently contraindicated in pregnancy because they haven't really researched it? That's in pregnant women, right? Vaccine's never been tried out.
Well, there were 37, I think, pregnant women that were accidentally vaccinated in that original trial, and they saw no severe adverse events.
Yeah, all right.
So
but they were not deliberately included in the...
No.
Yeah, and that is very common in a lot of the life-saving drugs, etc. We find that pregnant women and children are sort of contraindicated, not because there's real danger to them, but because there's just not enough data to say that it's not dangerous. All right, questions? Come on, it's the last session. You can ask anything you want. Yeah.
Hi, I wanted to ask if there is any cost effectiveness of this HEV vaccine in comparison to water treatment or other control measures which can prevent HEV.
Can you tell us a little bit about the cost of the vaccine? And
actually, I can't. We haven't done any cost effectiveness studies. But also in terms of the water and sanitation responses, we haven't seen any clear impact of water and sanitation, and so it's difficult to compare the two.
What's the cost of the vaccine? Do we know?
I don't know.
All right. Okay.
Sorry.
Yes, Alan?
Thanks. How common are hepatitis E outbreaks in the places where we work? I know there was South Sudan, but has it happened anywhere else where we've had to respond to a big outbreak of hepatitis E?
Yeah, we're almost seeing them routinely in our refugee settings. I've responded to 3 outbreaks in my time, and I've responded to 3 refugee emergencies, so yeah, all of them. So yeah, it's certainly a concern for us.
Fairly common. Yeah.
Becoming more common, I think.
All right. Oh, one more question.
Hi, Ruby. Great presentation. Not many people can make mathematical modelling sort of understandable. Is there any mileage in looking at single-dose vaccination, especially given kind of MSF's recent work on single-dose cholera vaccine? And secondly, how much did you include water and sanitation interventions in any of this? Or is there not that much evidence towards showing there's an impact?
Actually, through this work, we were also looking at the impact of water and sanitation in that Uganda emergency. And I think I've presented this in the past, that we simply responded too late in the Uganda. The outbreak had already peaked in all of the camps by the time we'd got our water and sanitation response together. And I think that's quite common for our water and sanitation responses. In terms of single dose, absolutely yes. We asked the authors of the Lancet paper if they had any data on single dose, and their study just simply wasn't powered to look at single dose vaccination, so they couldn't give us any data. But that would obviously be the ideal scenario for MSF.
Thank you, Ruby. I'm very glad that you worked peach into your presentation, especially in the week where Trump bought peace between Israel and Palestine. Thank you very much.
So we're very nearly at the end. It's my great pleasure now to ask Dr. Santosh Kumar, who's a board member of the South Asia Regional Association, to come up and do some closing remarks for us and remind us, hopefully, of some of the key lessons that we've learned today.
Good evening, everybody. And first of all, greetings to you all who are here from SARA, South Asian Regional Association, and the board. When coming to the concluding remarks, I promise I won't take much time, but just to summarize or to look at the presentations which have been here, which has been here, in terms of like how are we going to take this forward, and how are we going to take it forward as a scientific community and a civil society, and yet another point of view is how are we going to take this into the MSF movement. That's also very important, I feel so. So if you think of this AMR, it has been really a hot topic in MSF since last 2 or 3 years. It was a topic of debate in the General Assembly. It's again a debate in the International General Assembly also. So looking at it, I think it's like it opens like two battlefronts. MSF has been struggling. MSF has been fighting against the pharma industries, the multinationals, to reduce the prices of the antibiotics, to have more access, to get more people to access these antibiotics and all. And now what has happened is that much of the pharmaceutical industries have stopped research on new molecules of antibiotics because it's like it's not worth it means. The research itself is like huge, that they have other avenues which will fetch them more profits. So it has, on the other front, it has become our responsibilities to focus on governments, focus on civil societies, to invest more public money into this one so that we get more antibiotics to fight against this on the other front. And for the MSF, I think it's like a really, really critical situation in which we need to be more careful in when we design protocols in the field. We need to have a local microbial resistance patterns, hospital infection control, and maybe like hand washings, which has to be much more stricter. Hospital antibiotic policies, and maybe like newer tools. I was really wondering if we could have some tool which could differentiate between a microbial infection and a viral infection. Be much great in working in the field. So such things are really interesting for the MSF movement to work in this AMR policies or AMR issue. Regarding the climate change, I come from Kerala, which it's like almost a big problem there. Now rainy season is not yet begun, but still the dengue fever is on a high. Almost like 3,000 people infected in my institution itself. So the dengue fever was not there just maybe like 10 years ago. It's not there at all. So now it has become a big problem, and climate change has a huge impact. I think this is one of the places which would really bring in a globalization beyond borders. The issue is so huge that governments need to cooperate, Everybody needs to cooperate. Unless there is cooperation, there is no solution. So I think that's the issue is bringing in more focus on cooperation between governments, nations, and all institutions. So that's what I feel is a very important issue for the scientific community. And regarding MSF, I think it's like the impact is on that we might need to have to go to new places, new fronts to focus on different problems. So there has been lot of other issues which has been focused, which gives more insight. I'm not going into details of all these issues now, but I need to thank all who have been presented here, all the people, all the presenters, and all the moderators and the chairpersons who have moderated the sessions, various sessions. Special thanks to Philip de Cruz. He has been here for the last, he has been organizing all this whole session. On behalf of the board and for behalf of MSF, I thank you. And Sefi Shah, she has been organizing this thing for the last, the whole event has been designed by her. So we thank her, and I thank her Holly and her whole team who has been here the whole day, organizing the whole program. The live streaming is really wonderful. And the results of live streaming is that we have been close to 300 people viewing this one from 27 countries. And on Twitter, we got more than 1,100 tweets and retweets. It's really very interesting. And again, we had a good poster session also, and this was one of the first scientific day in which we have demonstrations and innovative research projects exhibited. So that's in that way, it's like a very new things coming in. So once again, I thank all who have been here on behalf of the MSF and on behalf of the board to be with us in this MSF Scientific Day. Thank you, and thank you all. Thank you.
Thank you for those closing remarks. And we're nearly there, the last couple of things. So I also wanted to add my thanks to Sophia, who has done an amazing amount of work and was not able to be here for administrative reasons. We really appreciate, Sophia, what you've done. We know you're online. Also to Holly, thank you over the last few months for making all of this possible. To the international and the MSF India editorial committees, you've done a great job in putting together such an interesting agenda. And also to the MSF India team for your hard work in just filling in the gaps and just making everything work smoothly. My apologies, because with such a good an agenda, the timekeeper, which was my only job, and I fell behind, but I think we're nearly there. We've got refreshments upstairs in a moment. I hope you will stay behind and join us and continue the discussions. Sorry to those online that we can't offer you a drink online. There will be probably an after party. You're all invited. News of where that is and what that is will be provided if you come up for refreshments upstairs. And maybe just a couple of final thoughts, because today we saw a lot of quantitative data, a lot of qualitative data, and I took away just maybe 5 final very brief thoughts. One is touch. We had 3 qualitative presentations that in one different way or another, the word about the hand upon the shoulder, the difference it makes, or how medical staff talk to patients, or trust between patients and doctors. So don't forget, we may be talking about these topics with these names like antimicrobial resistance, but at the very center is the humanity And I'm kind of shocked / renewed in enthusiasm that we need to remind all of our health staff of the importance of the humanity in every action that we do. Climate change, I hope you have been struck by how much that potentially is impacting. We're in the age of adaptation. It is impacting on healthcare. It is impacting on what MSF is seeing now. We maybe just don't realize it. It will be impacting on us in the future. We've only just started that discussion. Please think how we can take that discussion forward in MSF. Antimicrobial resistance, I pick up Tambury's one comment, are the days of one guideline over? And that scares me, because one of the greatest things, as Uni pointed out, that we've done in humanitarian medicine is simplify, and simplify again, because then logistics can work, then we can have doctors coming from everywhere with limited training by MSF to be able to just function in an emergency. So if we suddenly now have different guidelines everywhere, how are we going to manage? I think with antimicrobial resistance, MSF is only just beginning. And the lessons that we've learned from HIV and other things around task shifting, decentralization, around simplification, adding in areas of complexity that overall simplify your program, complexification to simplify. How are we going to start to think about some of these principles with antimicrobial resistance that in some ways is more complex? It's so many more diseases, it's not one disease, and we talk about it like it's one disease. And yet, it's often much shorter treatment if you give the right treatment, so it should be easier, right? Vulnerable groups. We heard a lot about adolescents, from MDR-TB to HIV, but that's because they're long-term treatment. Are we thinking about what adaptations we need to make in all of our programs for particular groups? If we're treating adolescents, I mean, I know often in MSF we talk about vulnerable groups and then we go under 5 and we go women, but actually are we missing what we should be doing in our services for adolescents across the board, in addition to the messages that our speakers gave us on the specifics? I was very impressed. We have the slogan, "Conferences without borders," but today we took it further. We had a panel without borders, and we had someone online. It felt like we were in the same room. I don't know about you, but I was impressed with the fish. Not to mention the great messages. Finally, I pick up on Joe's message, evidence. Evidence, what evidence do we need to get in our own area? Are we really conscious of the gaps of evidence in the things that we do every day? And we take for granted that this is the way MSF does things because that's the way MSF has done things. Do we have the evidence that that's really serving our patients? And I think we've heard a lot of presentations today that start to fill in some of the gaps and challenge us to look for more gaps and to get more evidence to do better. Fundamentally, MSF is about the humanity combined with evidence, combined with taking that to patients and making a difference. So, on those very mishmash themes, I bet you have your own 5. I encourage you to take time to fill in the evaluation form. That will give you time to think of your arguments upstairs while we're having refreshments, how you can come up with a better 5 than what I came up with. I hope you've enjoyed the day, and thank you very much for being here the whole day.